This is the last of 3 video lectures on failure to thrive, and this one is going to focus on medical and nursing management. You've heard the term, it takes a village. That's appropriate for failure to thrive. It takes a multidisciplinary team approach in order to implement the interventions that are needed to do the workup and then get this kid to eat. So the child and the family are participants. We have our physician specialist, the pediatrician, the gastroenterologist, possibly the oncologist, a hematologist, whoever is needed. Nutrition and dietitians are very important. The pharmacist may be involved. Case manager needs to be involved if there is a non-organic reason for failure to thrive. Occupational therapy and physical therapy are needed for the children who have an aversion to eating. Social services will get involved to make sure that the child is well cared for and that there is adequate financial resources. The psychologist may need to be involved, clergy, and then of course community agencies. And one of the biggest community agencies that we have is the WIC program, Women, Infant, and Children, that can provide food for a mother who is nursing, enough food to feed the family, or for a non-nursing mother, it can provide the formula for the child. So in the management, it's very important that we get an accurate history. What disease process or medical conditions does the child have at this time, and what have they had in the past? Ask the mother about weight gain and growth patterns. Was the pediatrician happy with how the child was growing, or did they say something to you that either they're not quite up to par and you need to feed the child more, or something along that nature? You need to find out the usual intake of patterns. How many meals does the child eat? How well does the child eat when it's time to sit down and have a meal? Does the child sit at the table with the rest of the family? Because there's a certain amount of socialization that has to take place for children to be able to sit and eat at a table. How much formula does the child take per day? Does the child prefer to drink milk over eating foods? And that child isn't getting adequate nutrition, number one, and is probably anemic because there's no iron and there's no vitamins in milk. What is the schedule of feeding for the baby who is on a bottle or nursing? How is the child's appetite, and have they noticed that there's a change? Has this child had feeding difficulties, and if so, how did the parents address it? When we get into the social situation, we want to find out if this family has adequate resources to provide for the child. Do they have any cultural barriers or family traditions that are interfering with the ability to provide adequate nutrition to the child? Watch what you say, watch your body language, and watch your attitude when you are talking to parents about their feeding. There might be a difference in opinion from one member of the family to the next about what the child should or shouldn't eat and how often, and should they take formula, should they take milk, should they be breastfed. There can be a lot of angst among family members. We do a thorough physical assessment, identify and treat conditions that can be contributing to the failure to thrive if there is a physiologic reason. We like to have consistent nursing care, as in the same nurse tries to take care of this child day after day. It's more difficult to do with the 12-hour shifts because nurses are working no more than 3 days in a week. But if at all possible, we want to have consistency so we can observe this child eating and we can observe the interactions between the parent and the child when it comes to food. We want to promote weight gain. And when we do this, we want to give them 2 to 3 times the normal calories until they're actually caught up. And this is going to be hard because some of these kids, they were on that low growth curve to start, so we have quite the job to do. We'll also be giving them vitamins and iron supplements, so we tend to give them just a multivitamin. It's a liquid format. It has its own dropper, and you give them 1 ml. And then the iron, it's usually 0.6 mLs of iron, and we'll talk a little bit more about that, I think, in the cardiac, but there's a standard formula that they get. So they take that every day. For some children, we need to actually insert a central line and begin TPN and lipids, because if their gut can't absorb anything, there's no point in putting anything in it other than to get this child used to eating. This child will get all of his or her nutrition through the parenteral route. For our cystic fibrosis kids and other failure to thrive kids that have a chronic medical condition, we may be giving enteral feedings. And so we can give them a bolus intermittent feeding, we can give them a continuous feeding, or we can just feed them during the night. And our CF kids oftentimes do that right at night. If we're going to feed the child by mouth, then we can increase the concentration of the formula. So instead of giving a 20-calorie formula, we can give them a 30-calorie formula. So we get more calories per ounce with each feed. We can give the MCT oil, which is medium chain triglyceride oil. That definitely increases the calories, because remember, the fats are 9 calories per gram. Proteins are 4, carbs are 4, alcohol is 7, and we're sure not giving them alcohol. We can give them very dense calories in the form of avocado. We can put sour cream on their foods, give them corn oil, margarine, and then for breast milk, we give them human milk fortifier that increases the nutritional quality of the milk. And then, like I said, we give them vitamin supplements. We might have to feed this child via a nasogastric tube. We may need to give them a nasojejunal feed, in which case they're only going to get continuous feeds. We can end up putting in a gastrostomy tube, and once we get that channel, then they're going to switch it out to the Mickey button so that it isn't so obvious that they have the tube. And then we can put in a GJ tube. So they have a gastrostomy tube arm and then a jejunostomy tube arm. And the jejunal part is for the continuous feeds. And the meds are going to go in the gastrostomy, because most of the meds need the acid from the stomach for good absorption. And so you can see what a gastrostomy tube is going to look like in the stomach. And their stomachs are very close to the abdomen, unlike many adults who have that thick fat pad. Most of these kids, it's going to be skin and stomach. Well, of course, you have to go through the muscle layer. So getting back to the multidisciplinary approach, OT, PT, and speech therapy can be involved to help with infant oral stimulation and oral exercises to get them used to sucking, and also helping our other kids, our toddlers, in desensitizing them. And that's for the kids who have the oral aversion. For family teaching and support, talk about the importance of having family meals and giving them feeding suggestions. What to put out for the child that is nutritious and beneficial. Stop giving them fast food and junk food. Avoid power struggles over food, because that gets us nowhere. It just the kid becomes belligerent and just says, okay, I'm not eating. Give them choices. Assist them with food preparation. Put a sticker chart up, and every time this kid eats the regular meals, they get a sticker, and at the end of the week, then they get something. And then refer them to WIC, get them on social support so that they can get food stamps if needed, and then, of course, the psychosocial support. So this ends the lectures on failure to thrive.